Welcome to our training topic today on trauma-informed clinical practice. My name is Kira McGilfrey, and I'm a licensed marriage and family therapist and the Chief Program Officer of School-Based Initiatives at Children and Families First, which is a nonprofit in the state of Delaware. And I'm here with Shannon, who will go ahead and introduce herself.
Hello, everyone. I am Shannon Fish. I am a licensed clinical social worker and the Director of Operations and Risk Management for Children and Families First. And together, Kira and I co-direct the Brain Science Training Institute.
The Brain Science Training Institute is a training program at Children and Families First where we offer training to organizations and the public on trauma, brain science, and the impact on individuals and communities. If you would like to know more information, you can scan the QR code and it'll take you to our website to learn more. We have a couple of objectives today, which is to understand the impact of trauma on the patient coming into the room and the client-clinician relationship and delivery of service. And then we'll look at some strategies on how to deliver services through a trauma-informed care perspective. So let's start off by having kind of a shared foundation of what trauma is. And there are many definitions out there, but we like this one, which is trauma is a threat or series of threats that overwhelms our nervous system, and it impacts our mental, physical, social, emotional, and spiritual well-being. Trauma usually involves an intense fear and threat to an individual's safety, and often involves a sense of helplessness. And what it can do is it can really overwhelm a person's ability to cope. So there are different types of traumatic events or classifications. We have acute traumas, which are one-time incidents. So think of perhaps a car accident or a house fire. And then we have chronic trauma, which is ongoing and cumulative stress. So examples of this may be ongoing child abuse or ongoing domestic violence. And then we have complex trauma, which is the experience of multiple and varied traumatic events. And so this means that an individual has experienced multiple types of events throughout their life that would be potentially traumatic. And then we have historical trauma, which is where we see discrimination and oppression, community violence, and racial injustices. And then we have vicarious trauma, which is the act of observing or witnessing the trauma of others. So you haven't directly experienced the trauma itself, but you have bared witness to it in some capacity. And we really see vicarious trauma with our helping professionals. So medical providers, first responders, therapists, social workers, for example. Ultimately, what trauma does is it stresses the body, and we'll go into more about what that looks like. We also want to focus on medical trauma. Medical trauma is kind of encompasses an array of different things, and this varies from person to person as to what may be traumatic. But these are some examples of things that patients have said have been quite traumatizing for them. So we have painful procedures. I mean, we can even think about how stressful an immunization shot can be for a young child and how much that provider and patient relationship is in helping that little kid move through that immunization shot. Then we have initial diagnoses or uncertainty about prognoses. So receiving a diagnosis or prognosis can be very scary for individuals, especially when there's this idea of death around that prognosis can be very traumatizing. There's also a sense of life threat, separation from family members. So if we can even think about a couple of years ago now with COVID-19 and the pandemic, family members were separated from one another. And that was very distressing and traumatizing for many families as they couldn't see the people that they love. There's also exposure to death or distress of other patients. So just being in the hospital and being around death or other events that may be happening. And then treatment setbacks. So individuals who feel like they're getting better and then they hear news or prognosis that there's been a setback can again be a lot for someone to handle and very stressful. Now that we've have kind of an idea of what are the different types of traumatic experiences one may have, we also want to talk about ACEs or adverse childhood experiences, which really refers to the toxic stressors that children may experience before the age of 18, which can have really this lasting impact on mental and physical health and just overall well-being. The experiences can lead to child and lifetime issues such as chronic health conditions, substance use disorders, and mental health complaints. And the original Adverse Childhood Experiences study, or ACEs, focused on what we called household stressors, which is what you see there in the tree. Since the original ACEs study that was conducted, we've since expanded it to include what we call those community stressors, which you'll see down by the roots of the tree, and then environmental stressors like climate crises, natural disasters. It's also, again, where we would see the COVID-19 pandemic. Now, why we're touching on ACEs is that we know that ACEs are quite common, that many individuals have experienced ACEs. And so our patients are potentially coming in with having experienced some of these stressors. Now, we always like to kind of highlight how these impact one another and how they kind of spiral off. So we have these environmental stressors, which can trigger household stressors, and which can then impact the growing of the tree, the health of the tree, and may lead to more adversities. And so we like to think if our roots aren't strong, then the tree can't really weather the storm that may be there. And so when we are thinking about our clinical practice, we want to think about how might these stressors be impacting the individual in front of us. Now, not all stress is bad. We have positive, normal, healthy stress where we have brief elevations in our stress hormone levels. And this is it's normal. It's what gives us the ability to get things done. We have this positive stress when we're going for a job interview or presenting in front of people or exercising. And then we have tolerable stress, which is a more serious but temporary response where our alert system is activated, but we're able to regulate back down fairly quickly because we have supportive relationships around us. Now, examples of tolerable stressors are medical injuries. So individuals coming into the hospital with a possible medical event that has happened. And when they have supportive relationships around them, it's a stressor, but it's more tolerable because of that. And then we have toxic stress, which is the prolonged activation of the stress response system, really absent of those protective relationships. And often this is where we see caregiver substance use, ongoing child abuse. But medical trauma can end up becoming toxic when there isn't a supportive and trauma-informed framework within the patient setting. So the provider is not being that protective, supportive relationship, and there aren't practices within the organization that are supporting that. So as we discussed adverse childhood experiences, what we see here are kind of those lifelong impacts of individuals who have experienced 4 or more ACEs. And as you can see, they're really not just behavioral or mental health problems. These impact the physical health and development of individuals. And so what we know is that individuals with 4 or more ACEs are 2 times more likely to smoke and 2 times more likely to have cancer or heart disease. And for men specifically with a ACE score of 6 or more, they're 46 times more likely to use intravenous drugs, and live 20 years less than men with no adverse childhood experiences. And you can really see from this chart how the adverse childhood experiences end up disrupting the neurodevelopment of the brain, and how that might impact their cognitive thinking and their ability to regulate their emotions, which then may again lead to adoption of other behaviors that are, not as healthy as other behaviors, which can lead to disease, disability, social problems, and an early death. And so, why we're talking about this today is really because we want you to be aware of the impact of ACEs and how you may want to think about asking about adverse childhood experiences or trauma or stress within your practice. And I'm going to hand it over to Shannon now, who's going to talk more about those trauma-informed principles.
So as Kira really kind of talked about, when we're looking at stress and its impact on the brain and on the body and on how individuals kind of navigate life, she mentioned in the vaccine scenario with children that our relationship and how we show up in the room can be the most positive change. We're in our setting not going to be able to prevent the ACEs that our clients and patients have already been exposed to, but we can change the relationship that they have in that one moment. And so it's highlighted best here by Dr. Bruce Perry, who says that relationships are the agents of change, and the most powerful therapy is human love. And that's really the foundation, the bedrock of our trauma-informed care principles. But next, we'll move through what these principles might look like and how they can show up in our patient-provider relationships. And we'll go through some of those skills and techniques. Trauma-informed care starts first with these 5 core principles. So we need to look at safety in the provider relationship. How are we providing physical safety for the client or the patient in the room, in the building, but also how are we promoting emotional safety? Are we able to allow individuals to have genuine, authentic feelings and emotional reactions that are validated and instead of judged? We also want to identify ways to promote trustworthiness, which looks like showing up consistently and following through on what we say we are going to do. Trauma-informed care also includes the concept of equity, diversity, and inclusion because of the roots of our tree that are embedded in the community where we've experienced historical and systemic and racism and discrimination. We know that individuals are coming into our relationship with those experiences, and we need to actively promote ways to address their inclusion and address equity so that they can feel safe and that they can trust their relationship with you. We also look at ways to promote choice and collaboration within the helping profession, identifying times where we can be able to allow an individual to have say, to give them multiple options, and kind of work with them through the problem instead of just telling them what to do at the end of the day. And we'll discuss this one a little bit more when we talk about motivational interviewing. And then finally, the last principle of trauma-informed care is empowerment, helping individuals see their self-worth and their value and being able to learn how to advocate for themselves and utilize their own strengths and their own skills. Embedded within these trauma-informed principles is the concept of clinical empathy. Without using empathy, we're not able to create that emotional safety or that trustworthiness. And if we can't do that, then they're not going to align with us and engage in the choice and collaboration. So empathy is the idea that we really understand and we see the person for their experiences. We're able to see and not to place value in what their experience might be, instead of only seeing it through our own lens. We can demonstrate this by making eye contact with them, being truly, fully present in the moment, not thinking about all the million of different things that we have to do after we walk out of that room, but staying truly present to what they're saying and attuned to what their body language is telling you, what their tone of voice is telling you, as well as being aware of your own body language and what that is going to be telling the other person, remaining very curious, and then also practicing ways to remain present, to really humanize the person. They're not just another piece of paper or a number on your caseload, that they are a true person who comes with you all of these different things, and they're more than just the sum of the presenting problem that they might have that day. And so empathy is being able to practice that trauma-informed care. Within building this relationship with them, we also want to identify ways that we can promote connection and resiliency. So the 3 C's that you see here are methods that you can use to build that relationship with someone so that they feel safe and valued within the relationship. It starts again with choice. This goes along with the choice that we talked about earlier, but it's looking at providing options, not dictating to an individual, but helping them see the various options in front of them and allowing them the opportunity to choose for themselves what makes the most sense. Providing connection also means having context. So as we are giving them those options, as we are seeking to understand more, we want to allow time to provide information, to educate, to clarify. And within that, we need to allow time for silence and time to process, because we're presenting lots of new information to individuals that for us is often very routine and matter of fact, but for them is very new. And they need time to think through before even knowing if they have a question to ask. And then finally, by using that empathy, we're able to provide connection. So we need to avoid judgmental statements or placing any type of context on what they're saying. We need to use a lot of supportive statements. And whenever possible, it's helpful to reduce the number of people involved and have a more one-on-one situation so that individuals feel safe and not feel overwhelmed by too many people in the room. Within trauma-informed care, communication is really critical to being able to have good, strong relationships. So effective communication has many parts, but these are 5 critical pieces. The first starts with being clear. We say clear is kind, but we want to make sure that we are being direct in the terms that we're using when we are talking about difficult subjects or sensitive topics. We don't want to walk around it or be ambiguous, because that will leave room for confusion, which can be very stressful and add to the stress of the situation. So when we are being direct, we're able to reduce their stress. We also need to be mindful of our word choice within the relationship. For us, we like to use a lot of jargon in our profession. We've learned lots of scientific terms. For other individuals, that can be very overwhelming. So being mindful of that and using layman's terms. And that doesn't mean that you won't still use the professional terminology, but then break it down for the person, help them put it into context that they'll be able to understand, which goes along with using those common terms and avoiding jargon whenever possible. As we know, communication is also not just about the words that we say, but it's about how we communicate those words, including what our body language is telling someone. So in order to have effective communication, we want to make sure that we are making eye contact, that we are looking at them, that when we are in the room, we're turned toward the individual. We don't have our back or our shoulder to the person. Whenever possible, we want to maintain an open posture instead of crossing our arms or kind of closing ourselves off. This allows the other person to feel that we're a little more open and genuine in the relationship. And then we also want to practice reflective listening, which we'll talk about in greater detail when we talk about motivational interviewing. So, motivational interviewing is a trauma-informed technique to help individuals make change. It came out of actually helping individuals make change with substance abuse, specifically smoking cessation. But we find that it really embeds the core values of trauma-informed care, and it can help create the safety and collaboration that we're looking for. So, some techniques within motivational interviewing start with reflective listening. Reflective listening is the ability to really genuinely demonstrate to someone that you heard the message they were saying. And it's the art of hearing what they're saying and then literally kind of summarizing it and reflecting it back to them to check it out and say, did I get that right? So, someone who's practicing reflective listening might hear a complaint that the patient has and say, okay, so what I'm hearing you say is, this is what brings you in today. And being able to kind of put that back so that the individual can say yes or no, or let's check this out together. When we're using motivational interviewing, we're also using a lot of affirming statements, which is acknowledging the person as worthy and capable of change, and that they are an individual who has the right to decide what this is going to look like for them. And being able to emphasize that as we're helping them understand the change that they might need to make and the impact that this is going to have on them. Within motivational interviewing, we also practice informing and advising. So, informing and advising is providing information and education, but it's doing so from the stance that we ask permission to share this information. And we allow the time for space and for thinking through and processing what we're sharing so that the other person really understands what they're hearing. As we do motivational interviewing and as we try to help manage the person through and motivate them to engage in whatever change we want, like start eating better or start taking this medication, then we need to use open-ended questions. Open-ended questions allow the person to have choice and voice within the context of making this change. So, open-ended questions mean if you ask a question, the answer can't be yes or no. By asking open-ended questions, we're inviting this individual to really have a say, to explore their own thoughts and give their own voice. And then this way they feel more engaged in the collaboration and they're more likely to come up with a plan that they can actually follow through on. Then finally, within this, we have summarizing, which is exactly what it sounds. Toward the end of the time together, we're bringing all of the things we've talked about together and we're putting it all together. And then we're using that reflective listening and we're reflecting it back to the individual to make sure that we are on the same page at the end of the day so that they know that we hear them and they hear us and we're together in that same plan so that the individuals are very clear about what is going to happen when they walk out of the room today. So now Kira will talk about practicing those trauma-informed care perspectives while conducting medical exams.
You, Shannon. So here, what you see are some potential causes for re-traumatization during medical exams, and then we'll move into ways that we can really prevent this. So vulnerable physical position can be very common for individuals who've experienced any sexual assaults or anything related, but in general, those positions just can feel quite vulnerable for any person. Lack of privacy can be potentially, again, re traumatizing, especially when it is related to that vulnerable physical position. Um, Limited kind of just awareness when individuals aren't necessarily aware of standard procedures and things done within the setting. It can be a little frightening. They can be taken aback about what's about to happen. Physical touch, again, depending on where the level of touch, where the touch is, that can be stressful. But also in general, some people do not like touch. And so we want to think about ways that we can ask for permission, like Shannon talked about earlier, when it comes to touch. A non-routine procedure. So anytime it's something that have not been familiarized with in the hospital setting can be stressful. So usually all of us are kind of accustomed to potentially x-rays and shots. But when there are other procedures that are not more normalized, again, that can become stressful for individuals. Anesthesia can be really stressful for individuals because there's a sense of helplessness. And if you go back to when we described what trauma is, trauma usually involves a sense of helplessness. And so that can be really re-traumatizing for folks who have had to deal with instances where they had no control. And then bias. So we all have biases. If we are not aware of those biases, though, and we're not taking active steps to address that, that can be potentially traumatizing for individuals as well. So we're going to discuss some ways that we can prevent the re-traumatization. So we'll start off by talking about before the exam. So before the exam even once begins, we want to create that relationship that we've discussed so much about. And we do that by having that identity affirmation. We want to know how the individual wants to be addressed. And this can be a simple statement like, how would you like to be addressed? And letting them tell you. As Shannon pointed out, we want to avoid using medical jargon. That can be very stressful for folks because they miss out on that context piece, which we discussed is so important. We want to check for nonverbal communication. So we're looking at our own body language. Again, as Shannon said, are we sitting with our hands crossed? Are we looking away? We want to make sure that we're providing that empathetic state. We want to avoid any sudden movements, especially for individuals who are experiencing post-traumatic stress disorder. Sudden movements can be very startling. We want to remain at eye level with the individual. So we don't want to exert this idea of power, which can be quite inherent when we have someone who's in a provider role. We want to make sure that the relationship feels collaborative. We also want to set an agenda of which body parts we will be looking at that day. And so this is just looks like saying, today I'm going to be looking at your eyes and your nose and your ears, and just giving people that prep of what it's going to look like. We also want to make it seem that whatever we're doing is standard practice. We really want to normalize it for folks. So example is, this is something I do with all patients who are coming in for a sore throat, for example, okay? We also want to ask about any comfort and concerns before the exam begins. So we want to ask and address any of the concerns that they may have. And then we want to offer a chaperone always for individuals who would like someone else in the room. Then during the exam, we want to make sure that we are keeping a line of sight and that we're introducing exam components. So for example, because you reported stomach pains, I will need to assess your stomach by touching around the abdomen for tenderness. So again, we're always connecting it to the medical reason and normalizing it and discussing what the components are going to be before we complete. We always want to ask permission before touching, even if it is a routine procedure. We want to stay within eyesight of the individual so that they can always see what we're doing. We want to respect personal space, so just being cognizant of where you're standing. You do not want to block the exit door, which can be quite stressful for folks who are experiencing post-traumatic stress disorder. And then we want to use simple clinical language. So of course, you want to use the clinical language as Shannon discussed, but you want to break it down and put it in simple terms. And then you also want to monitor, again, your nonverbal communication, your faces, your arm movements, and again, your eye contact. And then after the exam, you want to review it with the patient. You want to discuss what you did and if there are any concerns that need to be addressed. You want to also make sure that you're checking for understanding. So that's that summarizing part that Shannon also touched on is you want to ensure that they understand what was done today and the feedback. You want to let them know when the exam is complete. So just kind of giving them that note of when it is final. And then you want to discuss next steps with them and ask if they have any questions about the information that you reviewed with them. And the key here really is ensuring that folks do understand what those next steps are. And again, asking, do they have any questions or concerns about what you've discussed with them today? When we put all this together, we move away from this kind of what's wrong with you approach. And it turns more into this what's happened to you, what is right with you, and how can I help you today? And so, really kind of focusing on how you're going to be a support to the individual that's in front of you, what strengths they have that you can build upon when we're talking about change. And then, how is that help going to look like in a collaborative manner? So, it is goal setting and planning together. So here are our references for today's session. We hope you enjoyed the training and thank you very much.